use this. So my name is Sean Tan. I'm the Director of Pharmacy Operations here at Children's National. And with me is Demilade Haastrup. He is our clinical pharmacist, but also our informatics and quality assurance coordinator. So disclaimer, we want to share our success with everyone here. The only benefit that we gain are all the success that we have from using this platform. So just a little bit about myself. I am a Chinese-born native New Yorker, raised in Queens. I went to school in Western New England in Massachusetts, which I believe is where DIUC is actually headquartered, correct? Yes. Very good. All right. I was the clinical informatics manager at New York Methodist, which was actually bought out by Presbyterian. And before Demi joined, I was actually the one in charge of data, so I definitely know all the headache when it comes with those spreadsheets. I actually have a dashboard just for controlled substance with over 20 different sheets that's summarized. So that is still a nightmare, and hopefully DIUC is gonna help us much better improve that.
Thank you so much, Sean. My name is Demilade Haastrup. Rather than looking at the vibrating picture on the screen, you can look at me. I was born in Lagos in Nigeria. It's right on the middle belt of the in West Africa. I went to high school in Lagos in Nigeria, but I did come to the University of Cincinnati for my first degree. And then I moved on to Howard University College of Pharmacy, where I got my doctor in pharmacy degree. I graduated in the pandemic, yes. And as soon as I graduated, I had, a bunch of clinical rotations, one of them at Children's National Hospital. And, Sean brought me on the team in 2020 when I graduated in May, and I've been here ever since. I started frontline as a clinical pharmacist, but I did transition to the quality assurance informatics role late 2020, and now I kind of wear two hats. So I'm frontline 2 days a week, and then quality assurance and informatics 3 days a week. So I get to see both things, right? I see what the data is saying, and I actually see it on the back end of like how we put the data in, and I'm able to make it make sense while we do this.
So quickly, and this is almost like a continuation of Kathleen's presentation, because we are going deep into pharmacy and medication. So the medication life cycle, well, these are the steps that when we buy a medication all the way to when it's either being administered, discarded, or it's being returned. So unfortunately or fortunately, there are systems for each step, right? But it's a blessing, but it's also a curse, because McKesson, BD, KitCheck, IPAC, Simplify, Waters Chlor, Oracle, Cerner, dosage, come back to Cerner, going back to Vestigo, iSense6, License Track, Cactus Sync. So is it a blessing or is it? I don't know. So imagine I want to understand how good we're doing with our medication process. Am I going to run a report for all of them and then add? Well, that's kind of how we have to do it. But this is kind of the goal. So if we can take all of it and put it in under this one platform where I can just, build one dashboard that can tell me my entire process in one snapshot, instead of me running maybe 16 reports, luckily, if it's 16, and then to present up for me to know, what is my process efficiency opportunities? How are our staff performing? Because each step of the way requires someone doing a physical task. But if someone was doing it, is being hindered, as in every time they encounter this task, instead of them just doing it, they have to walk to the other side of the hospital or to the pharmacy. They have to grab something else only because they don't have it set up for them, or they encounter an error in the system. Has anyone encountered that before? So if the staff try to, I'm going to dispense this dose or draw up this dose, verify this dose, but system is saying, no, you can't because you're missing this piece. Okay, now they have to call someone, call the doctor, you didn't enter this information, I can't verify. Or when it's being verified and The technician attempts to draw up the dose, only to dosage says, you scanned the wrong barcode. Has anyone seen that before? Or the barcode saying, you scanned this drug and it's not in your work list. So those type of gaps is where having a holistic viewpoint of our just the medication process of healthcare is really worthwhile.
Speaking about the current state, so I remember December 2020, Sean reached out. Actually, what made Sean reach out, let's take a few steps back. A nurse, we have a stat turnaround time where we monitor how quickly it is that we get all our IV medications out from the point where the med was ordered to when the kid gets the med. We promise our nurses and our providers and other frontline staff that from the moment you order a med to when you get it out, we're going to get it out in 20 minutes if it's a stat, right? Before I came into the institution, it was like 120 minutes, but we were able to get it, Sean was able to get it down to about 20 minutes, and my job was to maintain it, right? So we had a complaint from a nursing staff about the turnaround time for a couple of meds on a couple of shifts. We went back to the employees and we said, well, you worked XYZ shifts on XYZ days, and on those XYZ days, the medications were delayed, right? But there was, the employees came back and said, well, if you have a look at this, the employees came back and said, well, I was working on that one piece of the drug. What happened to the other piece? And like, what happens to the other shifts? So Sean came to me and said, well, Demi, we needed to figure a way where employees can come and we can measure their efficiency. And we're able to take into account the different covariables. We're able to take into account if they worked in the morning shift or if they worked in the evening shift. We're able to take into account if doses were 3,000 on the day that they worked or if doses were 7,000. We typically do about 6,500 doses a day. Or if doses were 7,000 on the day that they worked, where there are 2 call-outs on the day that they worked, then they had to run a hoop and fill out 2 other holes, right? And being born late 90s, I wasn't going to use Excel spreadsheet for that. So I went out into the market and spoke to Vidina, and I was like, well, what can we do? I'm pretty sure there's a platform that we can put all of this stuff under, and we went out and then we found Diver. So right now, we can confidently tell you, Sean can reach out to me and say, hey, Demi, what was XYZ person's efficiency on XYZ date that they worked, accounting for the number of call-outs that were on that day, right? Right now, we've been able to integrate QGender, which is our scheduling platform. We've been able to integrate Dosage, which is the platform where we prep our drugs and verify our drugs and deliver our drugs under. We've been able to integrate Care Fusion BD, which is the Pyxis devices that basically house our meds all around the hospital. And we've been able to integrate some Cerner data, right? But a lot of that Cerner data would be in our phase 2 that you'll find out later on. But essentially, till date, we can tell you dose prepped efficiency. We can tell you who's reworking what the most. We can say, hey, they're reworking XYZ a lot because there were XYZ call-outs and they had to do XYZ more. And I think the biggest win for that is that we've just been able to do a lot of employee efficiency. Now, people can come up and tell Sean that they don't think XYZ other person's pulling their weight, and we can go in here and we can look that up and address for all the other covariables. And I think that's been a huge win for us to this point, current state. So we wanted to share our Iceberg. Our Iceberg is basically what you see on the top is I report to Sean, who reports to the Vice President of Pharmacy Services. But the VP would call and say, hey, Demi, I need to know what XYZ is or what XYZ was 2 weeks ago. And then, when I first started, I would use Sean's spreadsheet, and I would run the reports, I would update the pivot table, I would spend all that time doing that. Sometimes the platforms would be down, and I can't tell Sean to tell the VP that the platform's down, right? So all the stuff on the top is what people just ask for, and we're able to do them. But the bottom of the iceberg are the things that and Sean used to have to encounter to make the things at the top happen. And Diver has just been able to solve a lot of those problems for us now. It will, as we move forward, solve a lot more. But we just wanted to share this to give you guys like a picture view of what goes into what comes on top. And
don't try to read this, but this is sort of the fruition that Demi has been able to create. And just going back and forth, it provides anyone within our management team to know each process, each step of the way, how are we doing. We implemented some quality improvement theologies, such as simple as putting in an arrow. If the arrow, which direction do you want your data to go? If you want it to go down, you want to point it down so that people that may not be fully aware of the process know, oh, at least I know you're going in the right trend. So this is from a quality improvement standpoint. And if you want your data to be high, to go up, you put a up arrow. It's pretty simple. Also, Diver already has some of that integrated, as you guys do see the red and the green arrow, so we just incorporated those into our charts. And again, this is just one, how many systems is that? 5? 4 or 5 systems that we have thus far integrated, but we do have a lot more to go. Again, the goal is to share this data with staff so that staff is aware how they're doing. We spent over 2 million doses last year from our pharmacy, so people can get a little bit discouraged or feel exhausted, but when they see like, wow, I did 200 doses today for the shift, it makes them feel much more fulfilled in terms of sense, I prepared 200 medications, I potentially contributed to saving 200 lives. Our hospital is, our census this morning was about 326, but we are, spike anywhere from 300 all the way sometimes to 400 kids. So our ED is actually a 36-bed ED, but we do sometimes during peak respiratory season, we have at most 120 kids in our ED waiting. So incorporating this data and hopefully moving it out to other departments and bring that holistic viewpoint of how Children's National is making a difference for healthcare. So this is just us sharing with you guys some of our success. Of course, there's still a lot of work that Demi will need to do to roll out the other systems and make this even more powerful. And at the end of the day, is to paint a picture, is to tell a story. And the more, well, sometimes the more beautiful your presentations are, it definitely helps with telling that wonderful story.
All right, and we'll try to wrap this up in the next 2 minutes. The integration and validation process, Nora, Matt, Marissa's not here right now, but Nora, Matt, Marissa, Brian, they've been really helpful in terms of, we had a conversation one day, and it's easy to teach a clinical person IT skills, but it's harder to teach an IT person clinical skills. But having Nora on that team from the DI side, she has the clinical expertise, nurse by background. It made it really easy to work with them from our perspective. Like, I didn't have to explain what a dose verification, like dose range, 10% difference. I didn't have to explain any of that to her. Like, she understood things like that. So I think that for me, just to share that from a user perspective, was a huge win. We started this off with a service request, a simple service request, and that turned into laying out 3 phases, implementing the phase 1 that took about 300 hours. And we were talking about this 2 days, yesterday actually, because they did come on site, and 300 hours, that's not a lot, but that took us over 6 months, And the reason why that happened was more of a lag on our side. So if anyone's looking to implement something like this, you need to think about your peak seasons, right? There were days where I'd have to cancel meetings because I got pulled into work because there was a call out. That actually happened yesterday. I was supposed to be at the dinner, guys, but I got pulled into work and I have to staff till 10:30, right? So 300 hours spanned about 6 to 8 months. But so whoever's looking to implement this from a healthcare perspective, you need to think about that whole, hey, do I have the bandwidth for this? And if I have the bandwidth for this, is this 300 hours that I want to dedicate at the spread, or is this 300 hours that I want to dedicate at once to get to this level that we have gotten to at this point to integrate about five systems? We had to renegotiate our contract with our vendors. A lot of our vendors, like our Qiang scheduling vendor, dosage vendors, when we signed the initial contracts with them, we didn't sign anything that included auto-reporting or report pushing, right? So you need to think about that too. Whatever contracts you already have existing, when you want to expand to these third parties, do you want to renegotiate those contracts before you even start talking to DI or NORA about whatever it is that you're looking to do next? Right now, we have 7 subject areas. We are daily analyzing over 180 employees, over 10,000 shifts we've analyzed in the past year. We have 8 real-time, near real-time data sets. We have 96 measures. We have 83 charts that now when the VP calls for one of those, we just go in here and just pull one. He still thinks we're spending the time that we're spending on the other one. But, and obviously, we did face some barriers. Sean, you want to talk about this?
Anyone ever had IT told them, no, you can't do that? So IT governance was definitely probably the biggest barrier for us, especially in terms of cyberware, ransomware. So our IT actually completely locked down our network. They closed out a lot of data stream feeds. But that's why Demi still has a lot of work to do in terms of setting up more of these data feeds. And as Demi already alluded, right now we are actually approaching peak flu season. This is a new era in terms of having influenza and COVID. So from a healthcare perspective, I'm sure everyone is going into the dark, not really fully understanding what this season looked like with COVID happening at the same time. The cost, of course, it was definitely need some convincing for our VP to spend $60,000 when he asked, how come you've always been doing this with Excel spreadsheets, but now you want to pay all this money for it? And then finally, talent acquisition. I think it's everyone, any hiring manager has experienced that pain of trying to find the people, find the right talent, the person with that special eye that can tell you that, hey, there are better ways to do this than what you're doing now. So, at least for us, where do we want to go? Well, data is ever more powerful. Any Star Trek friends here? Right? You know how important data is, right? What has he contributed? Right. So I'm talking about, data, for those non-Star Trek people, data is actually a character, and he is an android. So, he saved quite a bit of people in quite a bit of occasions. So data is the future because it leads to everything else. Data also leads to artificial intelligence, which we are working with another vendor on AI and predictive analytics when it comes to controlled substance, diversion risk, diversion mitigations, and just improve awareness of people's practice that allows us to assess people's, not necessarily saying, hey, you're stealing, but your practice is deviating from standard, and that means you are more likely at risk of either diverting or losing a controlled substance. And then lastly, when it comes to automation, in the good old days, before Demi was born, pharmacy, we had labels that print out, literally hundreds of labels that just prints out, and you know how much work you have for that shift. But now everything's in the system, everything's in the cloud. So if you don't have a dashboard, if you don't understand the data, then you don't really know how much work you have. Especially when we move into automation robots that can make drugs themselves. If we don't understand data, we don't utilize data, then that robot probably sitting there and sucking on electricity for, you know, X many of hours and not doing any work. So that's the power of data. So thank you everyone for your attention. Hopefully we were able to share a bit of insight into the world of pharmacy. And Kathleen, I'll probably reach out to you for some of that other work you're doing. And we will take any questions. Right, yes?
I really like how you touched on adding the desired direction arrow onto the graph so that users could know what they were looking for even if they don't know the specific
Mm-hmm.
number. Thinking about those sorts of things, did you get any feedback about those types of indicators, or did you notice any change in the user adoption once you added that?
So yes, so actually we improved quite a bit. Oh, I'm sorry, to repeat the question about regarding adding the directional arrows to our charts, and have we seen any impact to it when we add it? So yes, so again, because people now understand what they're doing and people understand why we are saying we're not doing this good, or our process needs to be fixed. People didn't really understand why, or when we implement something, people didn't understand, oh, it's working. So adding those arrows kind of tells people, oh wow, what we're doing is making a difference, and therefore it makes people more inclined to adopt and to, you know, PDSA cycles, kind of adopt and inherit and continue doing, because it's hard to change. People says, you know, oh, we're changing this again. You know, we're trying something different again. But when they see value in what the change is, they're more inclined to keep doing it. Anything else? Okay. All right. Well, thank you, everyone.